Welcome to this new episode where we're diving deep into some of the more complex and critical topics in perinatal nursing. Today we're unpacking advanced clinical insights around neonatal and maternal care. Everything from managing newborns of HIV-positive mothers to fetal heart monitoring, obstetric emergencies, labor complications, postpartum changes, and infectious risks. It's a lot to cover, but these are essential areas for expert practitioners.
Absolutely, Liam. These topics really highlight the nuanced understanding required in our field. Let's start with the newborn of an HIV-positive mother. The key here is the prolonged monitoring up to 18 months, because maternal antibodies can persist that long, which complicates early diagnosis.
Right, and that persistence of maternal antibodies means that standard HIV blood tests can't reliably confirm infection until around 18 months. So we have to be vigilant with longitudinal follow-up. The modes of transmission are also important: transplacental during pregnancy, intrapartum during delivery, and postnatal through breast milk.
And that last one is why current guidelines strongly recommend against breastfeeding for HIV-positive mothers to prevent postnatal transmission. It's a tough recommendation, but the risk is significant.
Exactly. Therapeutically, newborns receive antiretrovirals, specifically AZT or zetavuudine, for 4 to 6 weeks after birth. We also watch closely for signs of immunocompromise, like hepatosplenomegaly.
Plus, the immediate bath after stabilization is crucial to remove any potentially infectious fluids. From a nursing perspective, this ties into immunity, infection control, and interpreting lab values like CBC with differential and CD4 counts.
And patient education can't be overstated. Emphasizing formula feeding, vaccination guidelines that exclude live vaccines until HIV status is confirmed, and the importance of follow-up testing.
That's a great point. The complexity here is not just clinical, but also educational, ensuring families understand why breastfeeding is contraindicated and why testing continues for so long.
Moving on, hyperbilirubinemia in newborns is another critical topic. It's defined as elevated total bilirubin relative to the newborn's age in hours, and we use a bilirubin hour graph to assess risk.
The physiology is fascinating. Bilirubin is produced when old red blood cells break down, normally processed by the liver and excreted in bile and urine. But newborns often have immature livers, and in utero, the placenta removes bilirubin, since the baby doesn't excrete it in feces yet.
That's why physiological jaundice typically starts after 24 hours, peaking around day 2 or 3. It's a normal transition as the baby's liver takes over. But if jaundice appears within the first 24 hours, that's pathological and demands immediate investigation.
Exactly. Causes like blood incompatibility or liver dysfunction come to mind. And the risk of kernicterus, irreversible brain damage from sustained high bilirubin, makes early recognition vital.
Assessment involves checking for yellowing of the skin and sclera, starting at the face and moving downward, ideally in natural light. Bilirubin levels above 12 milligrams per deciliter at day 2 or 3 are high risk, and over 15 is critical.
Management focuses on frequent feeding to promote hydration and bilirubin excretion, and phototherapy with eye protection. From a nursing standpoint, this ties into human development, liver metabolism, and nutrition.
Patient education here is key, explaining the importance of feeding frequency, adherence to phototherapy, and protecting the baby's eyes during treatment.
Now, fetal heart monitoring is another area where interpretation nuances can make all the difference. The goal is to assess fetal well-being by monitoring fetal heart rate and response to contractions.
There are 2 types: external, which is non-invasive with a monitor on the mother's abdomen, and internal, which is invasive and requires membrane rupture and dilation with an electrode on the fetal scalp.
The Veal-Chop mnemonic is invaluable for interpreting decelerations. Variable decelerations indicate cord compression, abrupt drops in heart rate. Early decelerations are from head compression and are generally benign, mirroring contractions.
Accelerations are reassuring. They show good oxygenation. But late decelerations, which occur after the contraction starts, suggest placental insufficiency and are concerning.
The non-stress test is also important. A reactive NST has 2 or more accelerations of 15 beats per minute in 20 minutes, which is the desired outcome.
We watch for bradycardia, tachycardia, late or prolonged decelerations, hypertonic uterine activity, and absent or decreasing variability. These patterns can indicate fetal distress.
When non-reassuring patterns occur, the first step is identifying the cause: prolapsed cord, maternal vitals like hypotension or fever. Then, stop oxytocin if it's running. Reposition the mother to the left side, administer oxygen at 8 to 10 liters per minute, and prepare for internal monitoring.
And of course, notify the provider promptly. Patient education includes instructing the mother to press the monitor button when she feels fetal movement and recognizing signs of infection if internal monitoring is used.
Speaking of emergencies, prolapsed umbilical cord is a true obstetric emergency. The cord precedes the fetus, risking compression and fetal hypoxia.
Assessment includes visualizing or feeling the cord, fetal heart decelerations, and the mother feeling something soft or squishy.
Management is very specific. Never push the cord back in. Instead, manually elevate the presenting part to relieve pressure. Position the mother in knee-chest or exaggerated Trendelenburg to use gravity to shift the fetus off the cord. And give supplemental oxygen.
Continuous fetal heart monitoring is essential, and preparation for emergent cesarean delivery is critical since the baby can never be delivered after the cord or placenta.
Patient education here involves explaining the positioning and oxygen rationale to the mother, which can help reduce anxiety during this crisis.
Then there's placenta previa, where the placenta implants over the cervix, complete, partial, or marginal. It presents as painless bright red bleeding.
Vaginal exams are contraindicated to avoid provoking hemorrhage. Management depends on gestational age, bleeding severity, and fetal or maternal distress. Often, cesarean delivery is required except in marginal cases.
Patient education focuses on reporting any bleeding immediately and possibly requiring bed rest in later pregnancy.
In contrast, abruptio placentae involves premature placental detachment, causing painful dark red bleeding, uterine rigidity, fetal distress, and shock signs.
This is a medical emergency with risk of massive hemorrhage and fetal hypoxia. Management includes monitoring maternal vitals, fetal heart tones, bleeding, fundal height, administering IV fluids and blood products, and preparing for delivery. Vaginal if partial abruption, emergent cesarean if fetal distress.
Also, monitoring for complications like disseminated intravascular coagulation and postpartum hemorrhage is essential.
Patient education here is urgent. Any bleeding or severe abdominal pain must be reported immediately.
Shifting to labor complications, preterm labor occurs between 20 and 36.5 weeks, with risks of immature lungs and organs.
Assessment includes regular contractions, cramping, changes in vaginal discharge, pelvic and low back pain, and premature rupture of membranes.
Management aims to halt labor with tocolytics like terbutaline, bed rest, hydration, infection monitoring, and continuous fetal monitoring.
Patient education emphasizes bed rest and recognizing signs like rupture of membranes, pressure, increased contractions, or back pain.
Precipitous labor is delivery within 3 hours of labor onset, more common in multiparas, with risks of hemorrhage and tears.
Management involves preparing for rapid delivery if the provider isn't present, having delivery supplies ready, and providing emotional support due to intense pain and rapid progression.
Patient education focuses on deep breathing, staying calm, and focusing on pushing.
Dystocia, or difficult labor, can be prolonged or extraordinarily painful, caused by hypotonic or hypertonic contractions, macrosomia, malposition, or pelvic abnormalities.
Assessment includes excessive pain, fetal distress, uncoordinated contractions, and stalled labor.
Management involves assessing fetal distress, notifying the provider, administering pain meds, IV fluids, tocolytics, promoting rest, and possibly oxytocin for hypotonic contractions with close monitoring. Now, postpartum physiological changes are extensive. Involution of the uterus and cervix occurs, with fundal height decreasing about 1 centimeter daily and remaining midline.
Lochia progresses through rubra, serosa, and alba stages, with vaginal bleeding lasting up to 6 weeks.
Breast changes involve a drop in estrogen and progesterone, a rise in prolactin, colostrum secretion for the first few days, and milk production starting around day 5 or 6.
Urinary changes include diuresis in the first 12 hours and risk of retention, while GI changes often involve hemorrhoids and constipation.
Menstruation return varies. Breastfeeding mothers may have amenorrhea, but can still ovulate, so contraception counseling is critical.
Discomforts include after pains, perineal pain, breast engorgement, nipple damage, mastitis, and emotional changes ranging from postpartum blues to depression and psychosis.
Management includes pain meds like ibuprofen and oxycodone, ice packs, sitz baths, stool softeners, hydration, nipple care, and emotional support with screening and referrals.
Patient education covers lochia progression, breast care, contraception, urination frequency, stool softeners, hydration, and emotional health awareness.
Postpartum hemorrhage is defined as over 500 milliliters blood loss vaginally, or over 1,000 after cesarean, with uterine atony as the most common cause.
Assessment includes boggy uterus, heavy bleeding, saturating pads in 15 minutes, and signs of shock, early tachycardia and restlessness, late hypotension.
Management involves frequent fundal massage, monitoring blood loss by weighing pads, labs for hemoglobin and hematocrit, medications like oxytocin, methylorgonavine, carboprost, blood products, and possibly surgical interventions.
Disseminated intravascular coagulation is a severe clotting disorder postpartum, with rapid clot formation depleting clotting factors and causing widespread bleeding.
It presents with bleeding from multiple sites, petechiae, purpura, and lab abnormalities like low hematocrit, fibrinogen, platelets, and elevated clotting times.
Management is supportive: labs, fluid replacement, blood products, heparin, and possibly hysterectomy.
Patient education includes recognizing bleeding signs and understanding the severity requiring urgent care.
Finally, torch infections are a group of congenital infections transmitted transplacenally, causing severe fetal and newborn complications.
They include toxoplasmosis, other infections like syphilis and HIV, rubella, cytomegalovirus, and herpes simplex virus.
Rubella has a 90% transmission rate if the mother is infected during pregnancy, especially in the first trimester, causing hearing, eye, heart, and CNS defects.
CMV is the leading infectious cause of hearing impairment and cognitive delay, with no vaccine and significant mortality in symptomatic infants.
HSV, primary genital infection during pregnancy, carries the highest risk, with cesarean delivery recommended if infection occurs in the third trimester. Breastfeeding is contraindicated with active breast lesions.
Varicella risk is low due to immunity, but early pregnancy infection can cause malformations. Newborns may receive immunoglobulin and vaccination if maternal infection occurs near delivery.
Syphilis has a high transmission rate if untreated, with significant fetal demise risk. Breastfeeding is allowed unless there are open breast lesions.
Screening, prevention, and tailored perinatal management are essential to mitigate these risks.
So Liam, after covering all this, what would you say is the overarching takeaway for practitioners?
I'd say it's the critical importance of nuanced assessment and vigilant monitoring, whether it's prolonged follow-up for HIV-exposed newborns, interpreting fetal heart patterns, or differentiating obstetric emergencies. The details matter, and patient education is integral to outcomes.
I agree. And also the interconnectedness of maternal and neonatal care. How what happens in labor and delivery cascades into postpartum and newborn management. It's a continuum that demands comprehensive expertise.
Well said. Hopefully this discussion helps deepen understanding and supports clinical excellence.
Thanks for joining us in this deep dive. Until next time.